next we're going to have Sri Vourganti come up and talk about considerations in energy modality selection.
Thanks, everybody. You're going to hear a lot of similar concepts, and it's really nice to follow Art and Amir just to emphasize this difficult topic. It's new, and deciding between energies is a very data-poor field, right? Because there's not really any quality evidence. We've come a long way. You know, we can see a lot more, and I got my personal introduction with this about 15 years ago up the road at the NIH, and you know, we're just getting to where out in the field it looked like that. So I got a little early introduction to this from Dr. Pinto and friends. But even then, we have the same problem. Like Art says, we have afraid patients. They're coming in with an elevated PSA, and the first thing they want is it to be cut out. Then they hear about side effects, and then they're like, why can't you just treat that little area, right? And so you enter into lots of discussion with them and balancing, you know, between things, and understanding that as we now know more and more, active surveillance is very appropriate. And even we had Dr. Gill sitting right here today and saying, you know, I'm really beginning to wonder if surgery is right for these people. We've come a long way now that we have a lot more data. So the enemy here is over-treatment and getting more people off of, you know, off of the book rolls. Active surveillance is really the answer, and you know, I think of focal therapy as an ally to active surveillance and maybe a little underarm to bringing a knife to a gunfight. So then you're delving into which of the so-called a la carte menu, right? And that's a very difficult one. And at this point, you know, most of the time when the patient says, hey, well, what's the evidence that I can follow it and I can give, I mean, because many of the people here, I have Dr. Klotz in the front, you know, they've done the hard work, they were the pioneers, and I can say, well, we have all this evidence, it's just fine, right? But then they ask me, they're like, okay, what do you want, what are we gonna do? Or why should I use one or the other? And now we have to talk about this, right? So how to choose an energy, there's no real data, right? It's very expert opinion oriented, and you can't believe everything you hear. There's a lot of marketing. And really, just like most people up here are saying, it's gonna be in case selection, case planning, who not to treat, and you're gonna hear rules that, you know, when you travel the world, you're gonna discover actually, you know, everybody's gonna break it, and getting expertise in one energy is probably the best thing, right? And understanding its limitations, when to use it, when not to use it, just like we do for everything else, right? This is a combined meeting between the Endourology Society, Focal Therapy, and Robotics, and we decide when to use robotics and SP, and when to stay in the retroperitoneum, and when we should do trans, and we have all these questions. We're still deciding stent or no, right? We're still deciding dust versus basketing, and there's a lot more of that than there is focal therapy, right? And so you have to have brave people making decisions, and it's not that there's no evidence, but you have to be able to, you know, trust your instinct and have rational reasons of doing things. So when you begin to tackle this, you're going to want to think about the differences, right? So think about what are some of the categories, right? There's routes of delivery, and these separate out, as Amr was saying. Needle, probe delivered, fiber delivered, interstitial methods are very distinct than beaming it in, right? There's thermal versus non-thermal, although I think sometimes people overemphasize non-thermal, right? They think that there's no AEs, and everybody knows these are demonstrated in the trials. Just because it's supposedly non-thermal, you know, there's still fistulas and injuries to neighboring structures and problems. And these things impact, you know, if it's getting hot, then there can be heat sink or margin control and things like that from distance of source. There's the site of delivery. This is very important, and this is regional. This is an international conference, so whether you do something asleep or awake can be very regional, or whether it's in the MRI gantry. You know, if I booked up a lot of time on the MRI gantry, that's a different business model than if we're doing it in the office or in the outpatient procedure. And you know, the dream is to do this awake in the office, and you know, you'll start to see things, but again, we have to establish that. How about treatment planning? You know, doing things straight cognitive is the baseline, and as we get expertise, we can do that. And there's absolutely nothing wrong with that. But new tools, as you can see, there's a lot of fancy tools out there that are going to help us. And so you don't need a car that can drive for you, but it's nice, right? It's nice. Intra-procedural monitoring is important. And then there's this learning curve, right? So there's an intense growth, right? The utilization of this is growing as we get codes and as it's less of a boutique operation and procedure. It's becoming more, it's leaving, it's certainly not standard of care yet in the United States, but it's leaving that experimental mode. And so reproducibility of this, training of this is important. How about practical differences to think about before we delve in? Well, availability, right? So if you have to, if you're interested in this and it's not around, then you have to pitch a business model. Some of these machines can be very expensive. And if you use it too much, then you might be violating patient selection, right? So you have to think about that, the cost, regulatory maturity. There are very viable platforms that just aren't as far down each institutional national pathway. So what's approved in the UK with NICE and everything, we might not have in the United States and vice versa. And reimbursement, I always tell my trainees and everyone around, I try to stay as far away from the bottom line as possible and just not think about it. But in the end of the day, you have to run a business. You have to have an operation that works. And we can't ignore that. And so if we say that there's no difference between energies and one reimburses a lot more, that has impact. However, this is a moving target. And so we really ought to remember we don't do radiation because we have a financial relation with the LINAC any more than we get kickbacks. We want to stay away from that. We want to do what's right for the patient. How about patient factors? And again, Amir talked about this, so this is very helpful. Lesion location matters, whether it's anterior or posterior. He called it north and south pole. I like that. Or hemisphere, I think he used. Perirectal, periurethral, neurovascular bundle, all important. Size, we're going to get into that a little bit, but both lesion size and gland size matter. Anatomy, whether there's things that can interfere, like calcifications, interprostatic implants, prior treatment, lesion biology. That's the last one. That's all supposition. These are the open questions. We don't know when we can stop. Is it wrong to treat Gleason pattern, ISUP4? Does that not die in ice? It does. We know that in the lab. We know that in patients too. So I borrowed this concept from Dr. Taneja, who's I think here in the third row. This idea, we call it focal therapy, but it's important that it's confluent, right? And as lesions need to get bigger, each energy is delivering different things. And so he had laid this out quite nicely, and I had adapted this. And so the idea is there are good things that come from being very focal, right? A smaller energy deposition can be tailored and shaped. I just saw Dr. Emberton put nice, almost like Tetris symbols. You can make it and tailor it. But and different energies have this. If you look at HIFU, certainly laser ablation defects, PEF, these sorts of things will deposit energy. But then you have this problem of keeping track of that, understanding where there could be gaps. And I intentionally left some little white dots there. That Swiss cheese is the problem, right? And so can there be a treatment gap? And most people know with experience you can avoid that, and there's ways around it. You can be more tailored, but procedure time, and so when you're smaller, so when you're doing smaller things, also size matters. And if you look at some of the early foundational work in energies like this, the median size of glands would be very small, right? So people weren't tackling big glands because they just took too long, right? So how about moving over the other end of the spectrum? You're less focal, but then you're more confluent. So you have a little bit more confidence. And the guess is that cryo and IRE and TULSA, as long as you're within that edge, there's going to be destruction from the center out to the edge. Now, sometimes there's a mystery of where the edge is, right? And so you have to use monitoring. So maybe in TULSA, you're using an MR thermometry model. In cryo, you're using the ice ball and sort of an understanding that at some point inside, there's that -20 isotherm and the -40. So this comes with experience. In IRE, it's all trust, right? Where we build these geometric structures. While you get bigger, there's less potential gaps, less Swiss cheese, but then the marginal control is more challenging, and you worry about the bull in the China shop model, where are we going to be able to stop? Are we going to be able to bend around a curve? This is more difficult. So what are some clinical scenarios? I'm going to go through some. So the anterior lesion, like Dr. Labachi said, is maybe you need to bring the energy to that. You're going to use more of a needle-based, probe-based, fiber-based approach. Doesn't matter which one. If you're beaming the energy all the way from the rectum, it's going to be a little bit more difficult. This is particularly true in situations where there's obstructions like calcifications, implants, and whatnot. How about above the urethra? You have to modify your treatment zone. You have to maybe take the catheter out during treatment. If you're you have to be cognizant of that. These are situations where maybe using an intraurethral approach with TULSA or something with the linear ultrasound would be helpful. How about a posterior lesion? We're going to go through some of these. Proximity to the rectum, neighboring structures, very important. What about ECE? What if you're very focal? You have to be able to bend. How do we know that some of the electrical conduction of IRE goes outside the prostate? We don't know, right? We think it might, but time will need to tell about these things. And then what if you have a large volume of tissue and an anatomic plan in a big gland, right? If you need to destroy 50 or 60 grams of tissue, are you going to be using the same energy? You need to know that each energy has a speed. So here's an example of a case with an anterior lesion, midline over the urethra. This is one where, I think I did the measurements here. It's telling you, in this situation, the blue mark is the mark that the radiologist made. It was an outside film. I always review it. And actually, the purple mark is what I deemed as being appropriate for the prostate and so when you measure this, it's like over 4 centimeters away from the rectum. You can get over that if all you have is a HIFU transrectal machine. You can get over that with a number of ways. You can compress the gland, you can do a TURP, you can do all sorts of things, but maybe that's not the exact right tool. You're going to use something that's a little bit more straightforward. And so anybody that has an additional approach in their armamentarium, and I used IRE on this specific case, but cryoablation or TULSA, that would be when you'd want to think about that. How about right next to the rectum, right? There's ways around it, but this is an approach where if the energy source is at the rectum and you feel comfortable in controlling it, a HIFU approach is a little easier, right? Now there's, again, ways to adapt this. If you're very comfortable and experienced, I don't mean to say that a needle-based approach or an interstitial approach is bad, but there are ways to make it easier. And many people are using rectal spacers in the same way that they can get treatment dose effect and drop off for radiation. We're adapting that same concept with ablation and to good effect. How about proximity to the neurovascular bundle? I don't want to mention all the reasons why one approach can be bad, but you'll have some flexibility, right? And so if you want to be able to have treatment drop off at the edge, you might use something more tailored to that. So what are some ways that you can get over the challenges, right? So if you have a very large treatment size, you'll see, or calcifications, and you want to use HIFU, for instance, transrectal HIFU, people will often tackle it with a pre-procedure treatment, like doing a TURP or a HOLEP ahead of time to get rid of this and make the patient more appropriate. For something that's very lateral, because there's a fixed distance of destruction, you're going to want to know intraoperatively to move treat it as a separate plan and almost do that drop method to bring the focal length closer so you're not depositing so much energy between the prostate and the rectum. How about with needle-based approaches? We mentioned rectal spacers. With thermal methods, if a lesion is right by the urethra and you have a warmer and you're icing it around, you're going to have some trouble getting within like 3 millimeters of the urethra. So turning off the warmer, being confident that these are sort of advanced methods. If you're worried about confluence, we mentioned that Swiss cheese model, double treatment has emerged, right? And this covers the fact that the gland gets bigger during treatment, monitoring it. And then what about margin planning? I think that this is one where intraoperative monitoring, checking our work, every energy is going to have its own method. But I'd like to highlight a couple things that we've come a long way, and procedural co-registration with MR fusion is very helpful, right? So you can make a plan, and we've definitely gone beyond just systematic biopsy. I needn't tell the people here, you're at a course that's teaching you MRI and the concepts. So, you know, we all do fusion here, I'm gonna hazard a guess, but what many people do is they don't bring that information to their surgery suite, they aren't reading their films, and so we get a lot more information nowadays, and this is an example of a focal therapy planning biopsy where you're targeting the lesion, you're getting a peri-lesional halo, you're doing a planned systematic, and all of that's kept track of. And so even in systems that don't have, and I don't know if that video is there, even in systems that don't have a built-in fusion system, most of the energy-based methods like TULSA, and they're going to have it built in, right? But if you're using cryo or IRE or laser, there are software tools that are going to help you understand. And so I think that as in the beginning, everybody's thinking in 2 dimensions. They're looking at that axial, but that Z distance, the depth distance and measuring that out can often get overlooked or underappreciated. And so, you know, when we're doing this, this is just an IRE plan where the actual imaging lesion is much smaller than that, and then you expand it to get a treatment margin, and then the IRE needles go even farther. But I know exactly the depth on the sagittal, and it's going to be following that. How do we keep track of this? And you saw Art showing these beautiful tools that are going to segment all the These are systems that are in place to help us get better. And so this is one, and most of the fusion companies are coming up with the other. But we're having an enormous amount of data that's being generated from the biopsy and the targeting and the planning and whatnot. And that's going to be coming into systems that we're going to be able to flip on and say, hey, where were my biopsy needles, right? And so. And then this being able to be exported to external systems. And these are all very important to keep an eye on, because I think that if it would be difficult to do, I can see why people skip it. But as it becomes easy or more straightforward, you'll find that you'll become dependent on it. Not dependent on it, but that you're happy that it's around. Open questions for energy. You know, these are the real questions. Do we have a way of looking at tumor biology and seeing which energy would work better? Right? These are the trials that need to happen. How about immune implications of ablation method? We talk about abscopal effects between cryo, HIFU, and thermal-based methods. These are all extremely important. What about combinations, combining methods? These are all very important. So it's very unlikely that any single energy is the best energy, to be honest, and they're all going to have their charms. The most important thing is picking the right patient, and particularly a beginner, just choose the right thing. Just like if you're doing robotics, don't pick that really hard case when you're starting. You want to build up your legs and then do the right thing. An a la carte method is not necessary with experience, but it's nice to bring the right tool to the right job. Each method is going to be unique, and you're going to want to talk to people. Thankfully, the pioneers are around. Many of them are here. They figured it out when, you know, and we don't need to make the same mistakes that they were able to figure out solutions for. Don't make those mistakes that come. Reimbursement is very influential in this decision, and I would say try to aim high, pick what's right, and we're working on it. We're making decisions, and codes are coming. It's not like the old days when people had to write checks and fly to the Caribbean and do all sorts of crazy things. This will happen, so don't make a big decision for your institution based on just how much money is going to be coming in. New methods are coming, and there's so many open questions. So thanks, everybody.